Good afternoon. Thank you for this wonderful
international,
and it's been my great pleasure and privilege to be here to presenting to you today. My topic here today is the cortical mapping for anesthesiologists. So first of all, I don't have any disclosures except for I do get a royalty from my chapters in Up to Date. And all the images are from the reference article or from the Google images. So as we all know, the advances in neurosurgical techniques has improved the overall quality of life of the patients and with the brain tumors and epilepsy. And total resection of the tumor or complete removal of epileptogenic focus is the key to the success. And lesions close to the eloquent areas pose a unique challenge to the neurosurgeons. There is a conflict between the main maximal resection with preserving neurological functions. There are well-established pre-surgical mapping techniques, for example, functional MRI, diffusion tensor imaging, magnetoencephalography, and PET scans. But still, there are some patients intraoperative stimulating mapping is indicated. So with this background, the learning objectives of my talk are to discuss the rationale and the outcome evidence for intraoperative cortical mapping, to describe different techniques of intraoperative cortical mapping, and then finally to touch upon on the anesthesia considerations for patients undergoing intraoperative cortical mapping, comparing awake craniotomy versus sleep mapping, and also on the choices of the anesthetic agents. As we all know that the cortical mapping is also called as the direct electrical stimulation, intraoperative stimulation mapping, or just stimulation mapping. Just touch upon a brief history. In 1874, Robert Bartholomew is the first person who showed that the motor cortex with a contralateral motor response in a patient who has got an exposed cortex as a result of basal cell carcinoma. But major work on the cortical mapping is done by Dr. Penfield from Montreal, and he did a lot of works, and especially in the epilepsy surgery. And the George Ogerman in 1970s is still considered as a pioneer of current mapping technique. Most of the language mapping and the also development of a handheld bipolar stimulator, so which are currently still in use, is all on the basis of the work of the George Ogerman. He enabled the precise mapping with accuracy of approximately 5 millimeters. And in early late 1990s, Taniguchi is the one who pioneered the motor mapping under general anesthesia using a high frequency multiple strain stimulation. So what are the rationale for cortical mapping is that the identification of eloquent cortex is very difficult because of the quite a bit of inter-individual variations, as well as the visual inspection, normal or abnormal tissues may be quite difficult because the resolution is not very good. And there is an intraoperative brain shifts which may affect the intraoperative neuronavigation methods. And the identified abnormal brain tissue may still have a normal function. And the most importantly, because of the pathological conditions, there is a brain plasticity which lead to neurophysiological and neuroanatomical dissociations, which is one of the main reason why we need an intraoperative cortical mapping. So regards to the outcome evidence, there are a lot of studies looking at the utility of intraoperative stimulation mapping or cortical mapping, and two main outcomes. One is they maximize the extent of resection. There's a couple of systematic review and meta-analysis that have shown that the maximal extension of resection was comparatively higher with the intraoperative stimulating mapping versus without the stimulating mapping. So maximizing the resection does improve overall survival and progression-free survival, as well as the improved post-operative seizure control in patients with epilepsy. The other spectrum is to minimize the post-operative deficit And one of the study from 2012 with the meta-analysis of 90 reports over 8,000 patients have shown that the intraoperative stimulating mapping does have a low postoperative neurological deficit compared to no intraoperative stimulation mapping. So before we proceed to the rest of the talk, so I just wanted to clarify a few terminologies which comes up with related to the stimulation mapping. And these are related to either to a stimulation part of it as well as the response part of it. I think as an anesthesiologist, we need to really understand this concept much more clearly because we are not very familiar with some of these terminologies. We probably heard very well. So one is when you're considering the stimulation, there is a biphasic versus monophasic stimulation. So biphasic is, as the name suggests, there is two phases. There is a positive anodal phase and the cathodal phase. And the pulse duration is the whole time from the anodal phase and the cathodal phase as well. In contrast, monophasic pulse stimulation is basically a single phase, only on the positive side on the anode phase, and that whole duration is considered as the pulse duration. When you're coming to the stimulators, there are two types of stimulators. The bipolar, the A and B are the typical ball electrodes or tip electrodes, bipolar stimulators, which is similar to electrocautery machines we are all familiar with. And then monopolar, the C and D are the monopolar stimulation. The main difference between them is that how the current is dispersed with the stimulation. As a bipolar, the most of the dispersion is between those 2 points. So only the area between those 2 points are usually stimulated. Whereas with monopolar, there is a much more wide diffuse spread of the electrical current in. So this is important when you're considering the positive mapping or a false positive, false negative mapping. So that's where what type of stimulator is used is important. When you're coming to the another important terminology, and especially for us, is the after discharge. The after discharges are the electrocardiographic recording during the cortical mapping. So for example, either they can use the grid electrodes on the surface while they're doing a stimulation with the blue tip here, or they use the classical Montreal or Medusa frame where you do electrocardiography along with stimulation. So these are like epileptiform-like discharges related to the stimulation. And when this discharge is lasting longer than the stimulation, they're called as the after discharges. And the important of the after discharge is that the recording electrocardiography does indicate that we can make sure that the electrical stimulation is delivered. You get a stimulation artifact. For example, in this figure on the right-hand side, at 3 milliamps, there is a stimulation artifact is seen that we know that the electrical current is just conducted through the brain. If there is no stimulation artifact, then we may have to check the equipments or we may have to go up on the electrical current. And we need to stimulate it till there is a positive changes which is felt or seen on the patient. And also we need to look for the presence of after discharges. So the stimulation, increases stimulation until the after discharge is seen, that is considered as the highest stimuli. So for example, here it's a 7 milliampere and 3 milliamps, there is no after discharges, whereas 7 milliamps, there is an after discharge in. So the stimulation mapping should be done within these two ranges, current ranges in. Usually the after discharges doesn't have any clinical implications, but it may indicate a continuation of after discharges, may indicate a subclinical seizure, and also there is a progression to a clinical seizure so that you can identify the onset of seizure earlier and then we can treat it sooner. Okay, so this is one of the classical onset of the after discharges and the onset of the electrocardiographic pattern of the seizure. When you're coming to the physiological responses, there is few terminologies we need to clarify. One is a positive response. When you're stimulating the cortex, so you may get a positive response as a sudden movement or paresthesia or visual changes with the pause genes, pause phenes. And with the negative responses, it can be a tingling, it can be a numbness, or especially with the language mapping, there is an interruption of the language function. And which should not be confused with the positive mapping or negative mapping. Positive mapping actually indicates that the functional important site is identified. And the negative mapping indicates that no functional site identified in the mapped area, or otherwise the area is considered as a non-eloquent. And this is important so that we can minimize the false positive and false negative. The false positive is a mischaracterization of a non-eloquent region as an eloquent region, leading to premature cessation of resection. And one of the common causes of false positive are patient fatigue, stimulation induced partial seizures, and also stimulation to remote structures by axonal propagation. In contrast, the false negative is the failure to identify critical eloquent brain region. And then if you go ahead and do a resection, there is a results in postoperative deficit. The cause for the false negativity is the inadequate stimulation setting and the inappropriate neurophysiological testing as well. So when you're coming to the neurophysiological testing, we can talk about it later. And stimulation paradigms, conventionally, there is only these two stimulation paradigms are used. One is the low frequency stimulation. Predominantly, most of the awake mapping is done with the low frequency stimulation mapping. And then high frequency stimulation mapping is predominantly done in asleep patients or under GA. Okay, as you also notice that there is a different type of electrodes and different type of pulse waveforms are used. So in generally, the low frequency bipolar is predominantly used for an awake craniotomy, and then mapping under general anesthesia is typically high frequency with a train of 4 or 5 with the monopolar with either monophasic or biphasic, especially if you're going to do a subcortical mapping. So that's what these are the two commonly used stimulation paradigm. When you're coming into the mapping function or responses, both cerebral cortical mapping, also subcortical mapping, depending upon the different regions, there is a different testing paradigm, things we need to do it. And I think that's beyond the scope of this lecture, how to do a language mapping, speech mapping, and the different parts of it. So if people are really interested in, I strongly recommend this article, which is just published in 2021 March in Frontiers in Human Neuroscience. The figures are from that article. It's one of the really a good review on this topic. So more important for us, the anesthesia and the cortical mapping. So intraoperative mapping of the most neurological functions occur in awake patients. And hence, intraoperative stimulative mapping is the most common indication for an awake craniotomy, which we are all very familiar with. However, general anesthesia or asleep mapping is still possible for a motor mapping. And there is a small case series where they said even a speech mapping is possible using a motor function of the speech testing, using electrodes in the vocal cord functions. There is a small case series demonstrated that motor speech mapping is possible under general anesthesia. So when you're coming to the awake craniotomy and the intraoperative stimulation mapping, it's very well established. And as you all know, there is two specific techniques, either asleep, awake, asleep, or monitored anesthesia care with no airway manipulation with the conscious sedation. And studies have shown that there is no difference between these two techniques with regards to the success or failure of intraoperative stimulation mapping. Similarly, the individual choices of agents, there is no specific technique which has been recommended. And the studies have shown that there is no difference between any combination of, so whatever the institutional specific, whatever one is comfortable with, that seems to be the best option of choice of anesthesia for intraoperative stimulation mapping. Just a word of caution, benzodiazepines and the opioids can cause a reappearance or worsening of a neurological deficit. So we did do a systematic review and we published it early last year. And I think this article just came out this month in Journal of Neurosurgical Anesthesia. Also, we looked at almost 600 patients having an awake craniotomy, and we used look at people who had a midazolam as a sedation for awake craniotomy and looked at the post-operative neurological deficit. And we found that there is the people who had a midazolam sedation compared to no midazolam tend to have a more post-operative neurological deficit. So we just submitted the abstract to Frontiers Oncology, which is in press, and we are working on the actual paper. And there is one small study we did compare the dexmedetomidine versus the asleep-awake sleep craniotomy, and which did show that the dexmedetomidine is maybe a better agent because patients were more awake and more able to perform the mapping much better. So the success rate of mapping was much better with the dexmedetomidine. And always there is a failure of awake craniotomy or intraoperative stimulation mapping. So the failure is usually defined as the unplanned conversion to general anesthesia and or premature cessation of mapping. And it is still incidence around 2%. And there are various causes of failure, including improper patient selection, patient preparation, patient cooperation. But two commonly comes topic on the causes of failure is one is the seizures, and intraoperative seizure associated with the stimulation mapping can be anywhere between 3 to 40% of people. And most of the seizures are related to stimulation. And that's why the monitoring the after discharges may be able to pick up the seizure early, and then most of the seizures that spontaneously recover. And using an ice cold saline Ringer's lactate solution seems to work very well, and most of the time you don't need any pharmacological agents at all. And again, the point I was trying to stress here again is that the monitoring the after discharges are using electrocardiography along with mapping. So seems to you can reduce the incidence of seizure by early detection of a subclinical seizures. And the second important cause of failure is the inability to communicate with the patients. The incidence is around 4.6%. And there are many factors, including the patient selection, language barrier, preoperative dysphasia, especially, and also using anti-epileptic, especially phenytoin. And they are all being considered as risk factors in this small sample size study. When you're coming to the cortical mapping under general anesthesia, not all patients can able to tolerate an awake craniotomy. There are some patients we may need to do under general anesthesia. So asleep motor mapping is gaining popularity, and we can do both cortical and subcortical mapping under general anesthesia. And there are various techniques that are being employed for mapping under general anesthesia. The first is the SSCP phase reversal. And then second is the trainer 4 or 5 high frequency stimulation. And the third is a combination of classical motor evoked potential monitoring in addition to direct cortical stimulation. And fourth is the continuous mapping by integrating the monopolar stimulator to a suction step as they suctioning out and resecting the tumor. So you give a continuous feedback to the surgeons in. And SSCP phase reversal, I think most of us are very familiar with this SSCP phase reversal. And this is used to identify the central sulcus so that you can identify the premotor, precentral gyrus or motor cortex. And so it's basically using a strip electrodes across the central sulcus and using an SSCP monitoring. So you can see that in the sensory cortex, the SSCP waveform is usually positive. And then there is a equal positive or negative at the central sulcus, and then you have a negative waveform in the precentral or a motor area, so that we can identify the motor area so that the direct cortical mapping can be possible following the SSCP phase reversal. And this is the classical sleep motor mapping with under anesthesia with the high frequency stimulation. Usually trainer 4 or trainer 5 stimulations are used. Since the patients are asleep, the response is usually done using an electromyogram. So in this figure, as you can see, this is the face and this is the arms and legs. So with the stimulation, I can see the activation of the EMGs in those muscles indicating a positive response. And for a cortical mapping, anodal stimulation is used. And then for the subcortical tissue, the cathodial stimulation is used. Studies have shown that is the high frequency stimulation is better than low frequency stimulation, and as well as the lower seizure incidence even in a patient with epilepsy. And another important concept is that especially using high frequency stimulation for a subcortical tissue, studies have shown that there is a linear relationship between the stimulation intensity, for example, milliamperes, and the distance from the corticospinal tract in the subcortical mapping. So for example, 1 milliamps current is usually equivalent to 1 millimeter distance from the corticospinal tract end. So that as the current comes down, so you can have this crude calculation to identify how close they are to a corticospinal tract end. Even though some other studies question this linear relationship, but most of the neurosurgeons still believe this relationship of 1 milliamperes equal to 1 millimeter of distance from corticospinal tract. And the combined MEP with the cortical and subcortical mapping usually done with the addition of a strip electrode. So it gives you, in addition to a cortical mapping, you can do a continuous motor evoked potential monitoring, and provides a predict information of the motor outcome, and they improve the safety of resection, because they do the mapping then followed by the resection. So during the resection process, they may cause more harm. So the continuous monitoring with an MEP may have an additional tool, give you information during the resection part of it. When you're coming to the anesthesia for asleep motor mapping, there is very minimal literature on this topic, and very small retrospective study on 49 patients. They compared awake and asleep mapping, and they showed that general anesthesia allowed reliable motor mapping, and there is no difference in the extent of resection between awake and asleep mapping patients. And the TY is most commonly used technique with no muscle relaxant after intubation. And inhalational agents, maybe MAC less than 0.5 is acceptable when you're using a multi-phase high-frequency stimulation. However, generally, most surgeons and the neurophysiologists are very reluctant for us to use the inhalational agents because most of the studies looking at the correlation between the stimulation threshold at the distance from corticospinal tract was validated only under TIVA anesthesia. As you all know, the intravenous and inhalational anesthetic may have quite a different effect on the cortical surfaces. So we don't know under inhalational agents, this relationship is, or this correlation still exists. So they still consider to use TIVA. And currently there are no studies which has compared TIVA versus inhalational agents. So in summary, the intraoperative stimulation mapping is increasingly recognized as a critical tool to guide the resection of pathology within or adjacent to the eloquent brain cortex. It can be performed under awake craniotomy or general anesthesia. Awake craniotomy has been the frequent choice for its feasibility of intraoperative neurological and neurocognitive testing. Variety of anesthetic regimens are compatible with the awake functional mapping, although dexmedetomidine seems to be beneficial. TIVA has been a standard recommendation when you're doing sleep mapping, and the role of volatile anesthetic can be used, especially with the high frequency stimulation, and but more work needed to study the effect of anesthesia and intraoperative stimulating mapping, as well as the effect on the overall postoperative neurological deficits and the other outcomes in. So with this, I strongly recommend anybody interested in. These are the two excellent, there is a more excellent reviews on this topic, but these two are quite important review. One is 2010 and the other one is 2021. So both of them are really a good review on this topic. And once again, I thank you, organizer, for inviting me for this talk. And this is the aerial view of early winter in Toronto. And that's my email address and my Twitter. And so if anybody is interested, if you have any questions, feel free to email me or send me a tweet.